A recent scoping literature review presented the existing literature on the diagnostic utility of anterior drawer test variations for diagnosing lateral ankle sprains in different phases of the healing process. In the next 6 minutes, I will break down the key findings of this paper and present you with clinical nuggets that will help you in your practice day to day and advance your ability to clinically reason when working with this patient cohort. To understand the importance of this and to integrate it into our clinical practice, we must first understand the problem. In clinical practice, it is most likely that primary care practitioners will see patients following lateral ankle sprains in the acute phase of injury, while secondary care practitioners will see them in the subacute and chronic phases of injury. And yet, all practitioners use the same test, the well-known anterior drawer test, to determine whether patients have suffered an injury to the anterior talofibular ligament, despite there being no clear evidence in the literature determining its diagnostic ability at different timeframes post-injury. Up to 70% of patients who experience an initial ankle sprain can go on to suffer from chronic ankle instability, which is associated with high levels of disability. It is therefore imperative we understand the diagnostic capabilities of this test at all timeframes following an injury to direct patients towards the most appropriate treatment. 170 articles were screened within this review and 8 were included in the final synthesis based on exclusion criteria, with a total of 921 participants. Studies were grouped based on the timeframe participants were assessed after injury. This study classified acute as being within 5 days of initial injury, accounting for the initial inflammatory process. Subacute was classified as 5 days to 12 weeks since injury, and chronic was classified as any time after 3 months since the injury at the time of the assessment, allowing for various definitions of chronic ankle instability. Diagnostic utility was assessed based on sensitivity, specificity, and likelihood ratios, with the latter being the more favourable towards clinical decision making. The most significant findings from the group studies were seen within the subacute phase of injury, where the highest quality studies were grouped to. The results demonstrated that anterior drawer test had a high specificity and strong positive likelihood ratio. The positive likelihood ratio is the most important as it takes into consideration our clinical suspicion based on history and clinical findings. A strong positive likelihood ratio means that a positive anterior drawer test increases our post-test probability of that person having a lateral ankle sprain. The data therefore suggests that we can diagnose a person with a lateral ankle sprain to a higher certainty based on a positive anterior drawer test, if completed within the subacute phase of injury. Unfortunately, the data trends show that a negative test is of minimal use to us in clinical practice at any phase of injury, and therefore other investigations and clinical history should be considered before ruling out injury based on a negative test. The results show weak positive likelihood ratio and only moderate specificity when using the anterior drawer test in the acute phase of injury, suggesting a positive test is not sufficient to make an accurate diagnosis of lateral ankle sprains in the first 5 days following the injury. The poor diagnostic ability of the test in the first 5 days of injury is likely to be strongly associated with the acute inflammatory process going on at this time. There is insufficient evidence to assess the use of the anterior drawer test in the chronic phase of injury. Included studies suggest it may have use at ruling injury both in and out, but unfortunately the data pool was too small and too high risk of bias to use within clinical judgment. So what does this mean for us in practice? Well, for clinicians working in primary care who assess these patients within the first 5 days of trauma, clinical history and presentation should be used to make a diagnosis. A negative anterior drawer test at any time point following an injury does not mean a patient does not have a lateral ankle sprain, and other investigations should be considered. The general data trend also suggests that the anterior drawer test is most useful when performed in 15 degrees of plantar flexion, and we should therefore consider how we perform the test when reviewing our results and generating a clinical hypothesis. Thinking about a clinical assessment pathway for these patients, we can follow a simple structure. For acute assessment, we should rule out fracture and then delay assessment of ligaments until at least 5 days following the injury. After 5 days of injury, the anterior drawer test can be performed to assess for injury or insult to the anterior talofibular ligament. A positive test at this point is sufficient to diagnose someone with a lateral ankle sprain and commence appropriate rehabilitation. A negative test remains insufficient to rule out an injury, and we should consider other investigations if our clinical suspicion remains high. Act with caution when interpreting the results of the anterior drawer test if using more than 3 months after the initial injury, as the evidence remains inconclusive. You should strongly consider your clinical suspicion and other clinical findings when making diagnosis, and let the test support your findings as opposed to changing your mind regarding diagnosis. And remember, the art of decision making includes the art of questioning. We must not just accept that a positive special test guarantees us that a condition is present, and must instead challenge our clinical reasoning with all available information and our awareness of the true diagnostic abilities of that test.